Right, we're going to get rolling with our next talk. It is great to see everybody. Good afternoon. Thanks for being here. We are really, really lucky this year to have kind of a whole spine theme, sub-theme in our conference with amazing spine faculty who've joined us. As you probably know, low back pain is the most common musculoskeletal reason that adults come to see us for musculoskeletal care in the US. So I think having an emphasis on spine makes a lot of sense for our course. Interpreting imaging of the spine, though, can be complex and confusing. And so for that reason, we invited Dr. Conor O'Neill to speak this afternoon on the topic of demystifying the spine MRI report. Dr. O'Neill is board certified in internal medicine, anesthesiology, and pain management. He specializes in diagnostic and non-surgical treatment for patients with chronic back and neck pain. Using a variety of methods, including both physical medicine and pain management, he works to enhance and restore functional ability and quality of life to patients with spinal disorders. Clinically at UCSF, Dr. O'Neill led the development of the Integrated Spine Service, a multidisciplinary team that includes non-operative spine and physical therapy providers who care for patients with complex spine pain. Dr. O'Neill's research is focused on improved diagnostics, innovative ways to treat back and neck pain, and developing new collaborative interdisciplinary models to treat back and neck pain. I can't imagine a better person to help explain spine MRIs than Dr. O'Neill, so please join me in welcoming him.
Well, I can imagine some, so maybe next year. So anyways, thanks. There it is, Carlin. And yeah, I do feel like I spend a great part of my time demystifying spine reports to patients. So hopefully I know can sort of give you some pearls on how I deal with that. It's my only disclosure. So the basic conundrum we face with most patients with chronic low back pain or any chronic pain of any type actually is just trying to figure out, is this pain central? In other words, is something going on in the nervous system, or is it peripheral? Is something going on in the spine or the joint or whatever? And I think most of us sort of instinctively assume that if a patient has pain, that it's because of some problem in the periphery, and that's why we pay a lot of attention to MRI reports. But the reality is that pain is so complicated and mysterious that in many patients it probably has nothing to do with their MRI scan. And we're going to talk a little bit about how to recognize some of those things today. So just as a quick reminder, acute pain is very simple. You break your finger or have some other injury. There's pretty much a direct correlation between the amount of pain you experience and the injury in the periphery. So that's pretty straightforward. Chronic pain is a different matter. Anytime you have a chronically injured or inflamed structure, this happens to be a facet joint, it creates this condition of what we call central sensitization in the nervous system. And basically, pain gets decoupled from what's happening in the periphery. And so this becomes very difficult to try and sort out, where is the pain coming from? Is it from this peripheral problem, or is it something that's now become part of the nervous system? This has actually become pretty well established. And in fact, even the lay press is picking up on it. This is from the New York Times a few years ago, had an article about the role of sensitization, and they pointed out that the microglia undergo this activation in patients with pain, and even went so far as to say we now know that your pain has a source. I don't know if that's exactly true, but and again, this just illustrates that we do know that there are these processes in the central nervous system that take place when patients with chronic pain, but we can't visualize these. We don't know. We can't see inside the brain or the spine to see what's happening with microglia. So for us, we have to rely on our clinical skills. The other thing that happens is, in addition to this microglial activation, there's also functional changes in the brain. So the pathways in the brain that typically are associated with pain perception, they change. They just change. And that's very obvious from functional MRI studies. some of these changes are probably reversible, but we don't even know that for sure. So again, these are things that we know they happen, but we can't really assess that in our patients. The other thing that to even make things more confusing is that in addition to this, the central sensitization can occur because of some chronic injury or other chronic dysfunction, but it can also be just constitutional. It's just a part of that patient. And there's these syndromes called the chronic overlapping pain conditions, migraines, irritable bowel, interstitial cystitis, et cetera. These probably all share a common underlying mechanism. And it probably has something to do with the way the nervous system is wired. And there's multiple genes that are involved with this. There's obviously environmental influences. So it's not like there's one specific cause that we're going to be able to identify and treat for this. But this is a really important thing to remember when you're assessing patients. If they have chronic low back pain and one of these other conditions, the chance that they have this underlying sensitization is high. And you need to be really careful about doing anything that's directed towards an MRI report, for example. So the primary indication for MRI, I think, as you all know, is rule out red flag conditions, these serious conditions like infections, fractures, tumors, et cetera. And I'm sure everyone here knows the red flags. The problem with these red flags is they're not very accurate, and particularly they're not very sensitive. So basically, since chronic low back pain is very common, red flag conditions are very rare, but in order to rule out these red flag conditions, we basically need an MRI scan. A lot of patients end up getting MRI scans, even though they don't have any of these, end up having any of these problems. So I'm just going to go through a few examples of just some patients that I happen to see over the years that I ended up getting an MRI scan, and they had one of these other, sort of serious conditions. This was a 28-year-old gentleman who came in with classic mechanical low back pain after a snowboarding injury. I told him, hey, don't worry about it. 6 weeks, you're going to be fine. He wasn't fine. So we got an MRI scan, and he had lymphoma, which ended up being treated with a bone marrow transplant, and he did reasonably well, at least the last time I knew about what happened to him. This is another patient who came in with classic back and leg pain. She had some degenerative change at the L4-5 level, which does this thing? No. This doesn't actually point at the screen, does it? No? Okay, never mind. And she had these degenerative changes at L4-5, but she also had, if you look up in the upper end of the screen there, you can see this little blob there that ended up being a drop metastasis from a brain tumor. This is a patient that came in with mid-thoracic pain. Again, seemed like it was just a strain or something, but she didn't get better with physical therapy. So she got a thoracic MRI scan, which is actually pretty normal. It didn't really show much. But then we did a CT scan of the abdomen, which showed this big hepatocellular carcinoma. And this obviously did not turn out well for her. This is discitis. This is usually pretty easy to diagnose on MRI scan, but many times they don't actually have infectious symptoms. So this is something that MRI is really crucial for. I think compression fractures, most people here are pretty familiar with those. And this is a patient that had some of the inflammatory back pain signs or symptoms and ended up having a sacroiliitis, which is characteristic for that disorder. So those are the things that we're trying to rule out with MRI scans. And of course, most patients don't have these things. So we tell them, great, you don't have any of these problems, you don't have a tumor. And most of the time, they're not really that reassured. They're like, okay, then why do I hurt? And that's where things, can go bad. So this is then they read their MRI report. Every patient reads their MRI report. They come in. They have all these, scary words on there: facet arthropathy, stenosis, disc herniation, severe this, severe that, annular fissures, and they are convinced that their pain is somehow related to these findings described on the MRI report. Okay, so this is where the problem really starts. Is that they can be due to those things, but most of the time it's not. This is a patient who was actually UCSF faculty, classic academic triple threat. She was like awesome clinician. She ran programs. She was a researcher. She developed back pain. She saw a surgeon who was convinced it was from her L3-4 level because she had some disc degeneration there. She had a artificial disc replacement. Before she had surgery, she was in pain, but she was working. Now she's working half-time. She went and saw another surgeon who thought, well, you also have some disc degeneration at these other levels. Let's treat those. Got those treated. No better. In fact, worse. And now she goes to Germany where they said, hey, let's just do them all. And now she's just 23 hours a day in bed, and her life functionally is over. So this can have some really serious consequences. And the thing that we should be doing, which some MRI facilities do, but we don't do at UCSF, is put epidemiologic data in the MRI reports. And some of you have probably seen these. They do them at Sutter, for sure, many of the Sutter facilities. And if you look at the prevalence of these disc imaging findings in asymptomatics, and maybe just focus on the 40-year-olds, they're very, very common. And even in your 20s, they're very common. So obviously, we cannot rely on these imaging findings in someone with pain to assume that there's a connection, a causal connection. For facet arthropathy, it's pretty much the same, except it's skewed a little bit towards the older group. It's less common in younger people, in younger asymptomatics, but still, relatively common. Stenosis is really interesting because you would think, oh, geez, if you've got severe stenosis, you must be in pain. That has to hurt. But in fact, only roughly 18% of people with severe stenosis have any symptoms whatsoever. But try convincing a patient who's got severe stenosis on their MRI scan of that. It doesn't go over too well. The other thing that's really important to remember about MRI scans is they don't assess myofascial pain sources. So your back is just not composed of discs and joints, but a lot of muscles, a lot of fascia, and all these things are highly innervated and all potential causes of pain. You cannot see these things on an MRI scan. So this is Janet Travell. She was a physician in the early part of the last century, I guess, who was actually trained as a cardiovascular researcher. And then for some reason, she got interested in skeletal pain. And she actually wrote the first paper that really popularized this notion of myofascial pain. There'd been some sort of things in the ether before then, but she really sort of took this on as being something that she was really interested in and wanted to pursue. You can probably notice that she's speaking in front of the seal of the President of the United States there. She actually became the personal physician to John F. Kennedy, who I think everyone knows had a lot of back problems. For your history buffs, you can see Pierre Salinger, JFK's press secretary, behind his shoulder there. So Janet Travell then became very prominent. She gave a lot of lectures. She traveled around. She published a lot about this concept of myofascial pain. And then she hooked up with this other guy, David Simons, who was another sort of character. He was in the Air Force, actually, as a physician studying space biology, and he eventually became an astronaut. And he was one of the first people to actually see the curvature of the Earth from a helium balloon 19 miles up in the air. So he got out of once he was no longer an astronaut, he went to the VA, started doing research, and he attended a lecture by Janet Travell, and then he just said, I'm all in on myofascial pain. I'm going to devote my life to figuring this out. So the two of them eventually published a book, Myofascial Pain and Dysfunction, the Trigger Point Manual. How many people here are familiar with this? I'm sure a lot are, yeah. So, and this is now in its third edition, and this book really, probably millions of patients and many thousands or more clinicians, have been applying the principles of this book to treating their back pain patients. And they were the ones that sort of came up with this idea of the trigger point. I'm sure all of you here, most of you here have identified trigger points in your patients, which is, it's a taut muscle band that has some type of probably inflammation that's associated with it, and that's what's causing pain. The problem with these is that they can only be diagnosed by hands-on. You can't get imaging studies to diagnose these. You can see the muscle bands on ultrasound, which is the top image there. There are some very sophisticated MRI techniques that can identify trigger points in trapezius muscles, but these are not really clinically available, and even if they are, the key point is someone has to actually put their hands on them and feel them and find out if they're tender. So these are things that are not seen in an MRI scan. And of course, if they do have a trigger point or some other thing, there's lots of things that can be done short of injections or surgery. The other thing is that obviously lumbar spine MRI does not assess the sensitization of the nervous system. That's something you have to do. And these chronic overlapping pain conditions that we discussed before are obviously key, but you can, I think most of you can probably tell when a patient has like pain all over and, they've got widespread musculoskeletal pain. More than likely there is something central that's causing their pain, and it's really important not to keep that in mind when you're interpreting the MRI reports. So just some take-home messages. First of all, obviously with MRI scan, primary role is just rule out these red flag conditions. The secondary is to identify targets for interventions, such as injections or surgery. So if a patient does fail all conservative measures, and there is some target in the MRI scan that potentially may be something that you can treat with an injection or surgery, then absolutely it's reasonable to do that. But the clinical correlation is so crucial, and that's just something that's absolutely missing many times, even in our own spine center. So you really have to assess the nervous system, the myofascial layers of pain. That's all really important. A few other things that patients sometimes get confused about is they come in, they say, well, I didn't want to go to PT because I need an MRI scan first, so they'll know what to do. I hope, are there any PTs here that believe that by chance? No. Okay, good.
I'm a PT, but I don't believe
Okay, good. But it's not uncommon that people do that. The other thing is defining prognosis. This is another big misconception people have. They're like, oh my God, I've got disc degeneration and I'm 30. What's going to happen when I'm 70? I should get surgery now so it won't be a problem later. Obviously not the right use for MRI scans. There's actually been quite a bit of data showing that the findings on an MRI scan do not predict future pain. And the other thing that I see a lot is just serial MRIs. It's like every time a patient comes in, they get an MRI scan. And they want, should we just check and see if something's changed or something else we need to do? And so obviously that's not something we want to do. Now I'm going to show a slide that Carlin's going to get mad about. So I think one thing that as primary care doctors is really important is because you're the first line of defense against this obsession that people develop with their MRI scans and the catastrophizing that develops when they read their reports. So this is Carlin mentioned our integrated spine service. Patricia Zhang here in the front row. Do you want to raise your hand, Patricia? She's the director of our integrated spine service now. And so, we see this. This is a message, a PCP sent to her patient after they got an MRI report. And I understand it's really hard as a primary care doctor. It's difficult because patients come in, they have the report. You're not, it's not really your thing to be figuring out what these things cause pain and they don't. But this is just absolutely classic for a message that can be delivered to a patient that can set them up for failure, no matter what their doctors tell them in the future. And there's actually been a couple good studies showing that providing patients with the epidemiologic data actually prevents or further care. So it actually eliminates future unneeded care. So this is just the way that we would present this information to them, is just really emphasize that these things are normal in your age. There's nothing you have to worry about. Your pain is probably due to weak and stiff muscles. You can be active. You can do whatever you want. You're not going to damage yourself. I think everyone probably understands these principles, but it can be really hard to get a patient to believe you. But the more that we all stay on message, the easier it is for everybody. That is what I have. So lots of time for questions. People, any questions? Anybody?
So,
Yeah.
so when would you say that it would be a good idea for PT, say they're seeing the patient and they're like, yeah, this is not getting stronger, this is not getting better. Is now a good time to refer them back to MD? Maybe can we get an MRI now to see if this is something that we just can't change?
Yeah, I mean, I think it's basically how they respond to treatment, right? So if they're not getting better, then they need more evaluation. Most of the time, probably there's nothing that can be done, but occasionally there is. So I think that's when it's reasonable.
Because what I found is when there's severe stenosis, foraminal stenosis, no amount of PT is going to change that. Because it's my experience, because it's being strangled like this and not being squished like this. And the pain is severe for them. And it doesn't seem to matter what is needed.
Yeah, I would.
I'm just curious.
Yeah, I don't look at it like that, honestly.
Yeah.
I think that I don't believe that nerves get strangled in general.
Well, that's how I do.
No, I understand, but because of this, the fact that it's so common to have severe stenosis and no pain. Yeah. So there has to be something else going on, and it's probably inflammation. Right. And why that happens in some people and not others, God only knows. So I think that's sort of how I conceptualize it, is there's something transient that's hopefully transient that's irritating the nerve and causing pain. Now, if they just have intractable leg pain is not getting better, then
it's not.
Yeah, then of course it's time to do something else. But that's sort of regardless of the underlying pathology.
When I usually am like, this is not happening.
Sure, exactly.
So.
Yes, Catherine.
Yeah, so it's interesting because I've worked in physical therapy for many years and treating back pain and that kind of thing, and did never order MRIs, but would definitely understand their response to my manual treatment, right? And I always kind of felt like it was a lot easier when you see the response to your therapy to help explain and understand kind of the MRI changes, because you're seeing a response to that care. Now that I'm on the NP side of things, and if I see that moderate to severe canal stenosis, it makes me a lot more worried. I mean, I know I still have my subjective exam and my objective exam, but I'm really wanting to send to spine in order to determine, is something non-conservative going to be more helpful at this point?
Yeah, I don't look at it like that. I don't. When I see moderate, it doesn't really affect me one way or the other. I think it's more about where is their pain. Like if they have back pain, and they have severe stenosis, it's almost irrelevant. I mean, I'm making generalizations. Go ahead.
Having claudication is limiting their exercise capacity. I think that's usually an indication.
Well, of course, yeah, but that's
All
that.
do is exercise. You don't want them to only be able to walk half a block before they start hitting.
Yeah, I mean, if someone has neurogenic claudication and stenosis, yes, of course, it's a different kettle of fish. But just because you see stenosis on an MRI scan and they have back pain, it's almost irrelevant.
No, this is an and situation. Like you see, there's stenosis,
Yes.
stenosis and they have neurogenic.
Yes, agree. Yes.
I don't know if my question applies, but I'm really curious because you said you do pain management also in general. Have you read the latest research on CGRP antagonists and pain management used for migraines? But they've been doing new research about it used in any kind of pain management for long-term chronic pain, and I just thought it was really interesting, and I just don't know if you've heard anything about it for lumbar back pain yet.
I have not.
What was that?
The question was,
The antagonists, so Nurtex and Adobe.
Oh, okay, got it.
So they're starting to use it trigeminal neuralgia studies and IBS studies because there's CGRP receptors all over the body.
Right.
And they're seeing that migraineurs have a lot of other issues, but not only are their migraines going away, all of their other chronic pain syndromes are going away. when you treat them with a CGRP antagonist. And so it's really interesting because it's just what are we going to see in the next few years when it comes to these things, because maybe resetting people's bodies and then taking them off that medication would be like, giving us better clinical exams, right? Because if you're talking all over, it's so hard to not order imaging when people don't even let you examine it.
Yeah, I honestly don't know anything about that. Sorry. Yes.
Do you ever recommend people see complementary medicine providers like chiropractors and naturopaths, or utilize any of those?
Yeah, all the time. I think if it's whatever works as far as I'm concerned. And if they don't get better, usually the first is physical therapy always. The only exception, some people just don't want physical therapy yet for whatever reason. But if that doesn't do it, then usually the next step is personally acupuncture. I sort of try to guide them towards that, but we've heard a lot to chiropractors too. And there's no issues with that.
I wonder if you can talk a little bit about the integrative spine service and kind of the approach to phenotyping back pain patients a little bit. And that might help. I would think it's interesting as a PCP to think about when I meet a patient with low back pain, is this person going to be high risk or low risk for having pain?
So Patricia, is okay if I speak for you, for the director of the integrated spine service? So in the integrated spine service, I think what we're trying to do there, or at least the original intent, was to really try and understand which of the patients we're seeing have mainly this peripheral pain problem, and which ones have more of a central pain problem, and in particular which ones are really have maladaptive beliefs like fear avoidance, catastrophizing, etc., that's going to impede their response to treatment. And so there's a tool that called the Start Back tool. I think some people are probably familiar with that. That's been developed that can help stratify patients to some degree into pathways. One is just plain old physical therapy, or maybe even nothing, home exercises. The other end of the spectrum is what we call cognitively informed physical therapy. So it's not cognitive behavioral therapy, because only psychologists can do that. But it's physical therapy that's informed by a knowledge of all these maladaptive beliefs that can contribute to delayed or poor recovery. So that's the idea behind it, is to try and, from the beginning, try and really understand these different processes that contribute to pain. And that's why we really encourage referrals to that service before they have an MRI scan, because that way, we can sort of control the narrative. Is that right? Patricia, you want to add anything?
And I think in more recent times, we've realized that it may be helpful to get patients in sooner, because I think that's one thing that's really hard. I know there's quite a few primary care doctors who are here today. You guys are busy. You are taking care of 20 medical conditions. And if it's going to take 3 months to get into the spine provider, you're going to be hounded with messages to get that MRI so that they could feel comforted that there's no concern. So I think lately we've been really trying to make integrated spine service a little bit more of a triaging service, because very much like what Dr. O'Neill is saying, it's helpful when that we sometimes get to them before they get that MRI, so that we put everything to perspective. And I think that's why this conference is really helpful, because we want to put the thought out there so that the athletic trainers and the physical therapists, when you're interacting with the patients, we want you guys also to share that message. Just because we see severe spinal stenosis doesn't mean that any back pain they have is absolutely from that, and they must absolutely have surgery. I think that was the main message I got from Dr. O'Neill's talk today.
Yeah, I think, obviously, to really get drilled down on what's causing back pain, it takes a long time. You have to spend a lot of time sitting listening to the patient. Patricia, in the what we call the ISS program, the patients are seen by both one of the PM&R doctors and then also a physical therapist. And it's great. It's awesome. It's really a nice way to, share each other's expertise and provides same messaging to the patient, because sometimes, as a physical therapist, a patient shows up, they've been told something by their doctor, and they go off on some tangent, and then you're trying to redirect them. It's impossible. So I think it's a great service, and you just can't do that in a busy primary care practice. There's no way. Yeah.
I have, I guess, 2 parts. One was coming off of that of how, like, in an anecdotal way, how many people do you think end up getting spine surgery that maybe never needed it? And then the second will be roughly of the sort of people that arrive in your service, how many would you feel have like kind of what's your kind of success rate that you feel like, okay, this is I know it's a really tough topic.
Yeah, success rate. I mean, it's so dependent on, like, if they come in with 20 years of back pain and they've got pain all over, and they won't bend their spine on exam, and they're obviously a fear avoidance. It's like maybe 1% chance of success, maybe something like that. Whereas if they come in with, just a pure back pain and they have a directional preference and, all these different other things, probably 75%. So it's just so hard you have to stratify it by, other conditions. Spine surgery, I'm in orthopedic surgery department, so I'm going to be circumspect. But I think there's a lot of people that don't need surgery that get it. That's what I'll say.
I was at this conference a few years ago in Europe, and that was one of the chairs kind of said that. He said he spent the first half of his career convincing people to get surgery, and the second half of his career.
Yeah, you hear that a lot from older spine surgeons. Yeah, there's a very famous one who his motto was that when he was younger, he fused, and when he was older, he refused to fuse. And there's also, I mean, it's interesting when you have spine surgeons come into you as a patient. I had one of the neurosurgeons, not from UCSF, they used to refer patients to me all the time. He came in when he was older. He had, bad pain and a deformity, I think, and something that could have had surgery. And I said, I can't do anything more for you, and I think you'd probably get better with surgery. He said, no way. He said, surgery is for patients. It's like, okay. Yes.
I was just, I'm just going to put a plug in potentially for, I don't know, for physical therapy, because, patients think that it's not only helping them, with therapy, but it's also an evaluation.
Yes, 100%.
And, I had a physical therapy evaluation, and it was the best evaluation I had. They have the time,
They touched you? They put their hands on you?
Yeah.
Actually, yeah.
It's really
No, it doesn't.
Physical therapy, and trying to convince patients that physical therapy is going to help them, it can be the best thing you can do.
Absolutely. I 100% agree. Yep. Yes.
I went to PT school in Tennessee, and we were trained in dry needling.
I'm sorry, trained in what?
Dry needling.
Oh, okay, yeah.
Obviously, we can't do that here. So I'm curious if you have any research, or if you've read any studies that compared dry needling and acupuncture, or if you've had personal experience with the relationship or the differences between those two dimensions?
Yeah, I don't actually, to be honest. I think around here, dry needling, I don't think is that common. I don't know. Do people?
It's illegal for.
Oh, okay. Well, that would explain it.
Athletic trainers to do dry needling in California.
Okay. I mean, I tend to refer patients, so we go one of two routes. One is acupuncture. I don't know. Honestly, I don't know any study comparisons. And the other is we have, several practices that we refer to that do active release therapy. And so that's sort of our other myofascial. I mean, I think most physical therapists that we work with will combine manual therapy. But there's some patients seem to need that more intensive. And they may include dry needling when they do the things. I don't know. Did you have something to add about that? Dry needling?
Acupuncture students do dry needling too.
Okay.
We do trigger point injections, and I often do dry needling when I do those.
Got it.
I was gonna say that, so as a PT who was trained in dry needling and can't use it here, I'm in a really unique clinic where we work hand in hand with acupuncturists who also do dry needling. So,
Okay.
if I would recommend like finding an acupuncturist that's kind of open to work and collaborate, and just kind of like building that relationship is huge, especially as a PT.
Got it. Thank you. Any other questions? Looks like we're tapped out.
Oh, I have another question.
Oh, you do? Okay.
Yes. Okay. So you gave us the example of where the PCP, had this interpretation that was different from the PM&R consultant. So what would the PCP, like ideally the PCP has this MRI, and is there, the PCP would like to refer the patient to a spine consultant. And so what would be the ideal message?
So I think the ideal message would be, and this is on my long list of things to do, but just to create a, what do we call them? Dot phrases?
Dot phrase.
That puts that epidemiologic data on there.
Yeah.
It's, a lot of radiologists do it, and it just says right there, these things are unlikely, or maybe, but it's the very common asymptomatics. Mm-hmm. And then you just put it out there, and then that way you don't have to.
Yeah. Dot lumbar spine MRI. Okay.
Yes, exactly.
But I think we also, as specialists, need to do better. I think one thing is if they're waiting 3 months to go see the specialist, they're going to end up come back and message you 1,000 more times. And you're like, what does this mean? So we are working to see how we can triage better. We've been doing some more televisits with PAs as well to, I think ISS now, we are trying to get people in the first 2 to 3 weeks. So if we can continue to make that happen, I think that would help. But you guys do so much.
Yeah, for sure. And part of the problem is if you want to refer to the spine center, they always ask, well, do you have an MRI?
Right.
If you don't have the MRI, we're not going to see you.
Yeah.
It's like, well, that's ridiculous. So that's what we're trying to change.
And then what about pharmacology? What about medications? We've talked about physical therapy, dry needling, acupuncture. Any role in your practice for prescribing medication?
Now we're talking about for non-specific low back pain.
Yeah.
Cymbalta. I almost always try to get someone to at least try it.
Why?
Because it helps.
Why not? Why not?
Well, there's data that Cymbalta is good for non-specific low back pain. The gabapentinoids I think are most useful for neuropathic pain. So I tend not to prescribe those for back pain. But Cymbalta, there's pretty good evidence that it works for back pain. There's been some randomized trials, and I wasn't trying to be flip, but that's why. Yeah.
So this is without reticular.
Yes, correct. Yes.
Okay.
Yes.
I missed that in the beginning.
Yep, pure back pain. Yep. It can help radicular pain too. I think the gabapentinoids are probably the first line for that for sure.
That's what I see. Seems to work better.
Yeah.
Especially when they take it at night.
Yes. Yeah, I prescribe a ton of Cymbalta.
Mm-hmm.
Did you have a question?
Yeah, when you recommend to chiropractor or acupuncture, what do you tell the patient about how those methods work?
So, first of all, you have to probe them a little bit to find out if they're open to things, because if they don't believe in it, it's not going to help them no matter what. And so sometimes people will sort of like, yeah, chiro, sure, happy to go to a chiro, Same with acupuncture. So I just sort of probe them a bit to see what they're open to, because if they're not open to it, forget it. It's not going to work. When it comes to I try not to get into too much to how it's going to work, because I have no idea. I don't think they do either, to be honest. When I went to an acupuncturist, I had a rib fracture, and they put a needle in my wrist. It worked. It was great. So I tell patients it's Chinese medicine. I don't understand how it works, but it works. Catherine.
Well, the other thing speaking to that too is one PT can be very different and give a very different treatment for
Yes.
the same problem as another PT, and the same thing with acupuncture. So it really depends on the training of the individual and as far as what kind of treatment within that practice and
Yeah, I mean, chiropractic is extremely variable. I mean, some of them they used a little, they call that thing, the little activate, whatever it's called. Yeah, some crack them, the traditional crack them, and some do just massage. So it's really pretty variable. Yes, sir.
What do you talk a lot about MRI? What do you think the role of playing radiography is for the lumbar spine? I'm thinking of a case of a 50-year-old guy, a smoker, back and tried to get an MRI, then that took a while. He wound up PT, got a little better, and they were just radiography.
Right. Yeah, I mean, I think in that is better than nothing, but unfortunately, it's just not going to pick up most of the red flag conditions. So I hardly ever order X-rays unless I'm trying to assess for instability or something that I can only see on a radiograph. But I think if you're in the wild and you can't get an MRI, then for sure I would at least get radiographs. Yeah. Yeah. Yes.
Just to kind of reiterate some things. So I do workers' comp, so obviously chronic low back pain is a bit of the pain of us, but I think people aren't get better. But I'm lucky enough to have an acupuncturist in my clinic. And one thing that I noticed with him in particular, other than the fact that he's a magician, is I feel like a lot of those people, kind of similar to what you were saying before, that you get to spend a lot more time with them than you do the doctor.
Yes.
And a lot of them tend to be borderline therapists as well.
Yes, 100%. Yes.
Chronic low back pain. So I feel like with a lot of them, like the good ones are definitely like you're kind of life coach while you're there.
Yeah, it's the therapeutic alliance. It doesn't really matter so much what your particular specialty is, but it's your ability to create an alliance with the patient that's so important. I have a PA that's absolutely fabulous. He's just incredible. And one of my patients said to me the other day, that Chris, he's so awesome. He can just heal with his words. It's just the nicest thing. Anyways. Any other?
I have another question.
Okay.
Okay.
We can go have a glass of wine.
I know, we can just... I'm just going to ask you about all my patients. So, okay. Can you describe a patient for you that would be the ideal patient where you're like, this patient's going to do awesome with an injection, and you can choose the injection? So like a great, like just teed up, this person is going to do awesome with a spine injection. What would be some cases, one or a few of like, yes, perfect indication?
So a perfect would be a patient with acute to subacute leg pain due to disc herniation. Okay. The reason is because they're going to get better anyways.
Gotcha.
No, truly. And the injection may hasten that. Might expedite that, but they're going to get better anyways.
Okay.
The other one that personally I think is I like seeing is people that have very localized joint pathology that's accompanied by inflammatory changes that is concordant with their symptoms. Mm-hmm. Those people will usually get better. It doesn't matter which joint it is.
So like, I have left-sided low back pain when I'm an extension, and I've got a L5S1 facet joint effusion.
Exactly.
Would that be okay?
Yes.
So and like you see that on MRI, it correlates well with their exam. Target that with steroid, they'll do well.
Yeah. So I think in general, if there's imaging is concordant with their findings, but that has to include not just like location of pain, but also their exam, like their mechanical exam. Mm-hmm. I think that's super important. And that's one thing, physical therapists do and chiropractors do way better than us. Mm-hmm. But that's something that's, has to be part of the thrown into the mix.
If MRI shows disc herniation and there's an absent reflex, is that a surgical candidate?
Did they have weakness?
Uh-huh.
Well, it's the weakness that's the surgical indication. The reflex doesn't matter.
Interesting.
Yeah. I honestly, I don't even test reflexes. because it's not a surgical. It's like you're not going to base any decisions on reflexes. It's weakness. If they, because the reflex might have been out for 10 years. You don't know. Now it can be useful sometimes in differentiating levels. Like if you see someone that has an L5S1 disc herniation, but they also have an L3-4, and you're not quite sure, then yes, it can be useful in that case, but not to determine whether it needs surgery.
Interesting. When I was 28, I had back surgery because I had an absent reflex, and I didn't have any back pain. I just had buttock pain. But maybe that's changed in the past 15 years. But that was the thing.
That they were worried about.
Yeah, I mean, I think if you had buttock pain and it was concordant with your imaging and you weren't getting better, you were weak. That's the key. But the reflex, I don't think so. Yeah. Yes.
If you have a patient that's had multiple discectomies before, and they come to you like this for the third time, and they're scared that they have another disc herniation that's severe enough that's going to need surgery.
Yeah.
But overall, their physical exam is okay besides the positive straight lesion.
Yes.
Do you get an MRI or?
So if they had conservative care yet, like physical therapy?
Yes.
Oh, yeah. If they failed conservative care, then yes, an MRI. But just based on that history of they've had prior surgery, they have a new pain with, what'd you say, a straight leg raise? So a positive straight leg raise test, but they don't have any other surgical indications because that's not a surgical indication. Then you have physical therapy first. And then if they don't get better, then an MRI. Yeah. Yes.
You start the bottom first or do you get MRI first?
In that particular patient?
Yeah.
Well, I think before you start Cymbalta, you have to, by definition, they've had chronic low back pain, right? So they need to have an MRI to rule out these red flag conditions. That's the problem. And that's why we face this so much. Now, I think what you're asking is a super valid question. Like, if they just come in with back pain and you didn't have this concern, and probably a lot of places maybe in other under-resourced settings, MRIs are rare and are difficult to get. I think it would be fine to do that. If they didn't have anything suggesting a neurologic problem with just back pain. But as a practical matter, it just doesn't happen here, in San Francisco anyways. Yes, sir.
Kind of weird question. You have a patient who's had already 2 spine surgeries, didn't really solve their back pain. They've been to 2 pain clinics and now they've been on Norco for about 6 years. And they're like, okay, I'm just going to take Norco until the end of my life. And they're in their 60s or whatever. That just cool.
That's cool.
I feel bad about it. I don't like that they've got something in there.
Yeah, no,
all the time.
Yes. No, I think you bring up a super important point is that, we've all been conditioned now. We were conditioned, 15 years ago to give everybody narcotics. Now we're conditioned to give them to nobody. But there's somewhere in the middle is the right place, right? And so I think it's really dependent on the patient. If the key thing is, are the narcotics making them functional? If they're improving their function and quality of life and they're not escalating their doses, I don't see any reason why not to. And particularly if they're older and their options start to sort of dwindle and they've had. Did you say this patient had prior surgery?
Yeah, like twice.
Oh yeah, and then each time you have back surgery, it's like your chance of success just goes down. So, so I think in a situation like that, I think it's totally fine. Now, it's still a pain. No one wants to prescribe them. It's you got to check. Cures, thank you. And I have contracts and all this stuff, but I think for the patient is probably the right thing.
That's interesting to me, and I don't prescribe opioids, but I think in the literature, and I just had to take that 8-hour course.
Yeah.
Because I do prescribe it. is that that's the key, is that if it's just this maintenance, is it really even giving them anything? Shouldn't you be trying to pull them off of it? I don't know.
Well, I think it's certainly reasonable to try, a trial to decrease their narcotics. That's fine, but I wouldn't push it. I mean, the problem is that there's so many patients now. Particularly now, like the classic example is someone's been on narcotics for 10 years and the PCP retires or dies or whatever. Yeah. And now they come into the new PCP and they're like, I'm not going to give you narcotics. You're nuts. And then it's like, well, is that really the right thing to do? I think a lot of times it's not.
All right. Well, great. Thank you so much, Dr. O'Neill, for an awesome talk.
Thanks. So you have a glass of wine to talk to some more?
Yeah, sounds good.
Okay.
More patients.